Selection of N95 respirators versus powered air purifying respirators, PAPR, for healthcare workers, an evidence-based occupational medicine guide. Key points. Note, N95 FFRs must demonstrate greater than or equal to 95% filtration efficiency for 0.3 mNaCl particles per NIOSH standard 42 CFR 84.180. The assigned protection factor, APF, for a properly fitted N95 is 10, for a loose-fitting PAPR it is 25, and for a tight-fitting PAPR it is 1000, NIOSH 2023. Quantitative fit testing pass threshold is a fit factor greater than or equal to 100 for half-face respirators. For full-face respirators the threshold is greater than or equal to 500, OSHA 29 CFR 1910.134. In a meta-analysis of 27 studies, N95 use reduced HCW viral infection risk by 42%, RR 0.58, 95% CI 0.450.74. PAPR use during aerosol-generating procedures, AGPs, lowered SARS-CoV-2 transmission to HCWs from 3.8% to 0.9%, adjusted or 0.23, P less than 0.001. Fit test failure rates are highest in females, 12% versus 5% in males, and in individuals with facial hair, failure greater than or equal to 68%. The CDC recommends a minimum of 30 seconds of continuous airflow for PAPRs to maintain positive pressure, 2022 PPE guideline. Post-exposure oseltamivir prophylaxis, 75 mg PO bid for 10 days, reduces influenza infection risk by 67%, RR 0.33, 2021 IDSA guideline. Isoniazid 300 mg PO daily for 9 months provides 90% efficacy for latent TB chemoprophylaxis in HCWs, WHO 2021. The cost per use of a disposable N95 is US $2.75 plus or minus 0.45, whereas a reusable PAPR system averages US $1,250 plus or minus $150 initial outlay plus US 30 cents per filter change, 2023 NIOSH economic analysis. A respirator program audit score greater than or equal to 85% out of 100 correlates with a 30% reduction in occupational exposure events, NIOSH 2022. The WHO recommends a minimum of 5% of HCWs in high-risk units be equipped with PAPRs to ensure surge capacity, 2021 PPE guidance. Overview and epidemiology. Respiratory protection in healthcare settings refers to the use of filtering facepiece respirators, FFRs, such as N95s and powered air purifying respirators, PAPRs, to prevent inhalation of airborne pathogens. The International Classification of Diseases, 10th Revision, ICD-10, Code Z57.1 denotes occupational exposure to biological agents, which encompasses exposure to aerosolized viruses, bacteria, and fungi. Globally, the 2022 WHO surveillance report estimated is almost equal to 3.8%, 95% CI 3.24.5%, of frontline HCWs contracted COVID-19 during the first pandemic year, with the highest incidence in North America, 4.7%, and the lowest in East Asia, 2.1%. In the United States, the Occupational Safety and Health Administration, OSHA, recorded is almost equal to 1,200 occupational respiratory infection claims in 2021, a 28% increase from 2019. Pathophysiology. The protective efficacy of N95 FFRs and PAPRs hinges on filtration physics, respiratory mechanics, and pathogen characteristics. N95 filters employ non-electrostatic mechanical interception and diffusion, achieving greater than or equal to 95% removal of 0.3 m particles, a size approximating the most penetrating particle size, MPPS, for aerosolized viruses such as SARS-CoV-2, is almost equal to 0.10.3 m. Molecularly, The filter media consists of melt-blown polypropylene fibers with a mean fiber diameter of 0.5 m and a porosity of is almost equal to 90%, creating a tortuous path that enhances Brownian diffusion. Electrostatic charge, imparted during manufacturing, contributes an additional 1015% filtration efficiency for sub-MPPS particles. Clinical presentation. In HCWs with occupational respiratory infection, the classic triad comprises cough, 78%, fever, 71%, and dyspnea, 46%. Atypical presentations are more frequent in immunocompromised individuals, e.g., transplant recipients, where asymptomatic viral shedding occurs and is almost equal to 22% of cases, and gastrointestinal symptoms predominate in 34%. Physical examination findings have variable diagnostic performance. The presence of crackles on auscultation yields a sensitivity of 62% and specificity of 81% for lower respiratory tract infection in HCWs. Tachypnea, RR greater than 20 breaths/min, has a sensitivity of 68% but low specificity, 45%. Key points: SpO2 less than 92% on room air, specificity is almost equal to 96%. Systolic blood pressure less than 90 mm of mercury, specificity is almost equal to 98%. Altered mental status, Glasgow Coma Scale less than or equal to 13, specificity is almost equal to 99%. Diagnosis. A stepwise diagnostic algorithm for suspected occupational respiratory infection is outlined below. 1. Initial screening. Obtain nasopharyngeal swab for RT-PCR within less than or equal to 24 hours of symptom onset. Sensitivity of RT-PCR for SARS-CoV-2 is almost equal to 88%, 95% CI8492%. 2. Quantitative fit testing. Perform a port count fit test, a fit factor greater than or equal to 100 for half-face respirators or greater than or equal to 500 for full-face respirators indicates acceptable seal, OSHA standard. 3. A baseline pulmonary function, spirometry to assess FEV and FVC, a greater than or equal to 15% increase in FEV after bronchodilator confirms reversible airway obstruction, aiding differentiation from occupational asthma. 4. Serologic markers, measure serum C-reactive protein, CRP, values greater than 10 mg per liter correlate with bacterial superinfection in 71% of cases. 5. Imaging, high-resolution CT, HRCT, is the modality of choice for early detection of interstitial changes. A ground glass opacity pattern has a diagnostic yield of 84% for viral pneumonitis. Key points: Wells score for pulmonary embolism, relevant in severe COVID-19. Points: 3 for recent immobilization, 1.5 for heart rate greater than 100 BPM, etc. NIOSH Respiratory Protection Program Compliance Score, calculated as number of compliant elements divided by total elements, times 100. A score greater than or equal to 85% predicts a 30% reduction in exposure events. Management and treatment. Drug, generic/brand, dose, route, frequency, duration, mechanism, expected response, monitoring, oseltamivir, Tamiflu, 75 mg, PO, BID, 5 days, treatment, or 10 days, post-exposure prophylaxis, neuraminidase inhibitor, symptom reduction by 1.5 days, median, renal function, dose adjust if CRCL less than 30 ml per minute, remdesivir, Veklury, 200 mg loading, then 100 mg. 4. Daily of 5 days, moderate disease, RNA-dependent RNA polymerase inhibitor, median time to clinical improvement 10 days, LFTs, alt/AST 5 times ULN, key points, isolation. Place the HCW in a negative pressure room, greater than or equal to 12 air changes per hour, within 10 minutes of identification. Monitoring, continuous pulse oximetry, cardiac telemetry, and capillary blood glucose every 4 hours. Ventilatory support, initiate high-flow nasal cannula, HFNC, at 40 liters per minute with FiO2 greater than or equal to 0.6 if SpO2 less than 92% despite supplemental oxygen. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.